So thank you very much for the introduction and also for pronouncing my name correctly. That's very kind. I'm a consultant hematologist at the Hammersmith, and I'll also be talking about side effects. So as you all know, we have this major target that we're trying to overcome with all our medication. So that's the principal aim of our treatment. However, unfortunately, they also cause what we call off-target inhibition, so that they inhibit some other pathways. And this is relevant because the reason for our side effects is the inhibition of these other pathways that we really didn't want to inhibit, but happen to be reacting also to the drugs. And one is related to the fluid retention and some of the fluid-related side effects that we have, as well as the skin changes. And another of the pathways is related to the blood toxicity that was also mentioned. So this is a list of side effects of imatinib therapy. So for everyone who has received or prescribed imatinib, the side effects are very familiar to us all. So for the skin, you can get skin rashes. All of the TKIs have a different spectrum of skin rash appearance, but with imatinib, it can be quite severe. Patients from Africa or India can get progressively more pale, so that changes their physical appearance. And you may have noticed that you burn more if you go out without your sun protection factor 50 if you are Caucasian. It can cause hair loss. Very rarely, it can affect the heart and also fluid related to impairment of heart function. Imatinib, it's a rare patient who can take imatinib on an empty stomach, so you have to take it after food, and sometimes even that causes sickness and vomiting. We speak about some other famous side effects of the TKIs, including diarrhea for bosutinib, but imatinib causes diarrhea in about 40% of patients, but I think most of our patients have decided this is the new them, and they are just going to accept this. We have to be very vigilant for side effects because more recently a warning for imatinib and the kidney function has appeared. We all know that tiredness is a big problem on TKIs, but I would say my personal opinion, probably the fatigue is more pronounced on imatinib and very difficult to tackle. Imatinib can cause constant watering of the eyes, eye bleeds, and also puffiness around the eyes in the morning that wears off throughout the day. Liver function tests we have to monitor for all of the drugs, but including imatinib. And of course, imatinib is very famous for causing cramp, bone pain, muscle pain, and weight gain, as we've already mentioned. It's not unique for weight gain, so you can observe this on the other TKIs. But if you have a spectrum of all of these side effects, then you question what's the point of having your wonderful major molecular response and complete cytogenetic response because your life is miserable. So side effects we manage with lots of other drugs to try and make the side effects either go away or that you tolerate the drug better. But the aim is not that you have polypharmacy, that you're on a spectrum of drugs, is that you have a normal quality of life, that you go back to work, and if one drug doesn't agree with you, then you should try the next drug to see if that's better. And sometimes we go back to least worst, but at least we tried to try and achieve that quality of life, because responding patients' survival is equivalent to that of the general population, or approaching that of the general population. If you reduce your dose, then it's very important that you're monitored more frequently. So it's not a blessing just to reduce your dose and we'll see you in 6 months. This has to be done in a specialist center that's used to dose reduction and adjustment of the drug dose according to side effects. So imatinib sounds pretty horrible, even though we say these drugs are very well tolerated, but there are some beneficial aspects. So patients who are on statins for cholesterol, they find that their cholesterol level has lowered in time if we're checking out, the GP's checking it, and some patients have come off their statins. Diabetes can get better. Some patients have either had hypos if they weren't warned about this, and some patients have come off their diabetic medication as well. And if you ever stop the imatinib, then it tends to go back to baseline on what your original status was. So we know that imatinib is our first drug, the longest experience, and then we have these other drugs, which we have 3 second-generation drugs, which are much more strong on the BCR-ABL, the target, rather than the patient, we hope. So dasatinib was the next one. This is an order that was introduced into clinical practice. So it's 300 times more potent than imatinib in the laboratory. And you can see on the right-hand side that it's much better tolerated than imatinib. All those other niggly side effects that you have on imatinib are not present on dasatinib, but you have this major appearance of something called the pleural effusion, just up there, headache, and it's more strong against one of the other pathways, so the blood count can be lower. So if we look in more detail about the pleural effusion, this is what it typically looks like when it's been allowed to develop. So it will start very small, and if you don't tell your doctor, it will start increasing, and then it will be on both sides. And what we really want to do is to be aware about this, because it doesn't happen all of a sudden, and that we don't want to be called by our cardiology and chest colleagues to say, I think this is something to do with the drug that you've been given. We know how to predict it, so you must never split your dose of dasatinib. You can only split imatinib, but don't split the dose of the other drugs. If you're age over 60, I'm afraid the chance is higher. And if you have pre-existing chest or cardiac problems, then also there's a higher risk. It's not heart failure. It seems to be an immune reaction, so some sort of allergic type reaction that's caused this. And if you have a history of that in your family or in your history, then that can predict. But the good thing about the pleural effusion, if there's ever a good thing, is that patients respond a lot better, and you can reduce the dose of the drug and then carry on with the good response without having to interrupt treatment. So how you treat it is there's only the 3 ways that you treat it is stop the drug. There are some other types of approaches that we have, which we do to hasten the resolution of the pleural effusion. So we can give a short course of steroids. The aim is not to be on steroids forever, just a period of 3 to 4 weeks of a low dose. We don't use water tablets that much because that's not the mechanism. It's not heart failure, but patients on dasatinib can also retain some fluid. So the main take-home message is that if you are breathless, if you have a cough, if your exercise tolerance, you can't walk up the stairs as much as you did, then you should consult your hematologist, because the sooner we investigate this, the sooner we can treat it, and it is reversible. So I mentioned some other interesting aspects of the drugs. Dasatinib can interfere with the coagulation, so how your blood clots. It's not as high as when we had the higher doses of dasatinib when it was first introduced, but it does affect those platelets which come together to form a clot when you cut yourself or you bleed. But all the other drugs seem to have an effect on the platelet function as well, but dasatinib is the one that particularly causes worsening bleeding. It does have the same impact on as aspirin, so we don't know the real mechanism for this. But for dasatinib in particular, and possibly imatinib, if it's very sensitive surgery, we say to stop the dasatinib for 7 days before the surgery, and when your surgeon is happy that the bleeding has stopped, then you can resume your dasatinib. It's very important in the current climate of the NHS, if you're cancelled, not to stay off, as we've had patients that have been off for many months waiting for their surgery to happen and they've lost their response. So please use this approach very carefully in collaboration with your doctor. There is an increase in pressure around the blood vessels around the heart, which is called pulmonary arterial hypertension, which is the interaction between the heart and the lung. It's around 0.2, but also for the minor type, 5%. So this happens when you're breathless. Doctor does a chest x-ray, there is no fluid that's expected, and then you go on to be referred to a cardiologist, and this is diagnosed. It is semi-reversible, so again, very important that it's tackled very quickly, but most of the patients that were investigated didn't quite go back to baseline. If we then look at LataNib, which is 30 times more potent than imatinib in the laboratory, again, much better tolerated than all the niggly side effects on imatinib, but you see there's itching and also the rash, which is different to the sort of red rash that you get with imatinib. Seems like goosebumps under the skin, you can't see them, you can feel them, and they are incredibly itchy. So that shows the spectrum. It also a little bit kinder sometimes on the blood count than imatinib. We can check any adverse effects on the blood, which is your liver and kidney profile, and the bilirubin, which is the blood test which makes you go yellow if you have jaundice, hepatitis, or gallstones. That can increase, but it's not harmful. Unfortunately, nilotinib does increase the cholesterol, so 20% of patient studies will go on to a statin after starting nilotinib. It worsens diabetic control, and 15% of patients will develop diabetes that weren't destined to develop diabetes on nilotinib. This shows the circulation side effects. So there is a triad of heart attack, stroke, and arterial occlusive disease, which is pain in the calves when you're walking and occlusion of the arteries in the legs. It is related to the dose of the nilotinib, so the higher the dose, the higher the incidence of this spectrum of arterial occlusion. If we look at the rate on imatinib, it's 2%. Most centres say it's 10%, but in Austria, they published that their rate was around 40%. So it's very important that all of us are aware of this. Bosutinib is the last second-generation drug, again 200 to 300 times more potent than imatinib in the laboratory, and its famous side effect is that of immediate diarrhea. So we do warn the patients. We say don't go shopping as soon as you have taken the drug. Make sure you know where the nearest toilet facilities are and have some Imodium just in case. But that happens quite instantly. Patients don't come off bosutinib because of looseness of stools, but they come off because of abnormal liver function tests and also because the counts can fall. How you manage the diarrhea, so the standard dose is 400 for a newly diagnosed patient or 500 for a second-line patient. So our practice is to start on a much lower dose, which is 300 milligrams, then nothing happens, and everyone who's taken Movicol, lactulose, Xena is very upset when nothing happens, when they don't get a swap of the effect for the bosutinib. And then we work up according to the dose. Important, of course, to be careful of your diet, just so you don't stress the bowel too much. Reassuringly, bosutinib doesn't seem to have any different cardiac or circulation type side effects in comparison to imatinib, which is something that we really look at, particularly because ponatinib, which is the strongest drug that we have against the BCR-ABL, it's extremely potent, but does also have a spectrum of side effects. We spoke about the dry skin. The dose of ponatinib was 45 milligrams, but on lower doses this hardly ever happens. But patients came with a sort of crepe appearance of their skin, and when we did a biopsy, all of the skin was lifting off. It's not uncomfortable, it's constant exfoliation. There's usually a trail of skin in the outpatient department and over the partners complain about the excess hoovering, but it's not uncomfortable, but is annoying and frustrating and responds to reduction of the dose. But more seriously, the rate of these arterial side effects with ponatinib was around 10% in the first year, and in the initial studies this went up to 40%, of which 30% were some sort of event that you had to intervene, stent, or operate on. So we treat this very cautiously. We try to reduce the dose of ponatinib as soon as we get a response, and then some of us consider giving aspirin, certainly I do, for all our patients, although the evidence is not present for TKI-treated patients, but it's present for other conditions, and then we consider whether we should do some other measures for patients already taking aspirin. So the take-home message is that the sooner you intervene, the less likely you're needing to intervene. If it's affecting your blood, stopping the TKI, so interrupting until you recover, is a very well-established method. We give white cell boosters, which are injections. We try not to give blood transfusions, so we give an injection called EPO. We have been exploring giving a platelet booster called thrombopoietin, but we've gone off that because it tends to make the circulation side effects much worse, and of course dose reduction with the precautions that I've already measured. If it's affecting the other organs, as we said, interrupt until you recover. Great steroid users, either as a cream or short course of tablets for liver, skin, or those sorts of side effects. Dry eyes, false tears are quite helpful. Taking an antacid for the sickness and the indigestion, the gastric irritation, which can happen on some of them. I never remember which TKI is less absorbed with lansoprazole or omeprazole, so I usually say take it away from the tablet when you take it. Anti-allergy medications, very useful for the itching and some of the allergic type reactions, and of course dose reduction. Statin and aspirin for the cardiology side effects would tend to work with the GP because we don't have as much experience. We're not trained in cardiology. We don't know which blood pressure medication we can advise on the statin, but there is a whole effort to try and standardize this for our patients that are more at risk of getting these cardiac complications. So the screening test that you start before the start of therapy, everyone needs hepatitis B because only a small percentage of patients reactivate the hepatitis B that they've already recovered from. And then for particular TKIs, we measure the lipid profile, the diabetic control. Everyone with a second generation drug onwards needs a baseline ECG. If you already have cardiac problems on dasatinib, you need an echocardiogram before you start dasatinib. And because of the method that how ponatinib works, it can cause the thyroid function to become worse. So we tend to check if we need to replace with thyroxine. So in summary, we are very focused on progression and getting a good response, but we're also trying to tailor therapy according to the baseline problems and other drugs that patients are already taking. And it's very important that we don't have any side effects that we cannot correct in the future. We are screening cardiovascular risk factors, but essentially trying to liaise with our cardiologists and primary care physicians to manage that. And it's very important to know, although your hematology doctor is excellent and has a wide base of knowledge, you would not ask your cardiologist how to manage their your hematology, and the same approach should also happen to the hematologist with all respect. The last message is that you can blame the drugs for everything. So you can say everything is because of this drug that I'm taking. So it's important also to make sure that your general health is also being investigated and that nothing is left untreated because this was attributed to the TKI. And I know we're late, so I'll thank you for your attention and perhaps take questions later during the break.